Okay, great. I'd like to thank TopCon and the other physicians for inviting me to share my experience. It is definitely, as Vas said, it's an evolving world with respect to the images that we're seeing and these technologies, and I think the information is changing very rapidly. So these are my disclosures. Is there a way to fix the screen so we can get the view to be a little bit different, so we can see this a little more clearly, to shrink? Obviously, I'm a speaker for TopCon. So basically, I want to give you the key take-home points right off the bat. OCTA is an evolving imaging modality, which we've already seen with Vas's amazing talk. SWEP source, of course, as mentioned, is a longer wavelength at 1050 nanometers than what we're traditionally used to at SDOCT at 840. The penetration through media opacities is superior, and we're going to see some great examples of that. And particularly when we look at OCT angiography, which is so sensitive to motion, so sensitive to media, and also very rapid, getting access through media opacities is very key. Obviously, we mentioned this rapid image acquisition time with SWEP source, and ultimately these technologies, as they're evolving, they are going to be limited in, as we are with our understanding of them, with motion artifacts and segmentation. So we'll look at some of those examples. So successful OCT imaging, I think all of us can agree that we are not, the doctors aren't the ones who take the images every day. Our technicians and photographers are the ones who take the images. And really the key to successful imaging, which we can all agree on, is a cooperative patient, a reasonable media clarity, having a device that's easy to use, easy to integrate into our clinical practice, and something that allows us to have robust software and post-acquisition analysis. And that's what really gives us a really robust device. So taking a look at that, in challenging technology, the challenge in comparing technologies such as SWEP source and spectral domain is we're not really comparing apples and apples. They are different in a number of ways. First, of course, in the way in which they acquire images. They acquire images differently. They use different segmentation algorithms, and Vas pointed out earlier that segmentation is very key. The differences between segmentation algorithms can be the difference between detecting membranes and detecting pathology or missing, and we'll see some examples of that. And ultimately, there is a post-image acquisition processing that occurs with every machine, and these technologies do this differently. So while I am going to present some information on spectral domain and SWEP source, it's important to realize that devices themselves are designed and built very differently. So the TopCon Triton, as was presented earlier, is a SWEP source, the first commercially available SWEP source device at 1050 nanometers at 100,000 A scans per second. It offers multimodality imaging, which we've seen. It offers OCT angiography at 3.5, 4.5, and 6, and even 4 millimeters of view, and at 1 micron wavelength. So this is a pretty robust device. So let's take a look at something in our real-world practice. Many of us may be vitreoretinal surgeons who see patients with gas, and most of us see patients with cataract, and we all fear the fact that we have patients that have massive amounts of blood in their eye. All of these pose a barrier to acquiring day-to-day routine transverse OCT-B scans, but of course would pose an even greater barrier for OCT angiography. So just in the last week, I put together these 3 cases from patients that came in the clinic. We can see a patient here with post-op day 1 macular hole surgery. This is a patient with post-op day 1, 95% SF6 gas fill. The fovea is clearly visible. Obviously, this is a very myopic fundus. There was no adjustments that were made in order to acquire this image. The 1050 nanometer wavelength goes through this very easily. Here's a patient with wet AMD with 3+ cataract. Again, very clear view through media, through hazy media, but very clear view of the retinal architecture and the CNVM. And finally, on Thursday before I left for this meeting, we saw a patient with this massive subhyaloid and diffuse hemorrhagic presentation of PDR. And again, another great example of penetrating through blood. And you can see the hyperreflective material underneath the hyaloid, but a very clear view of the retinal architecture with very little backscattering. And those of us that have up to this point been using spectral domain OCT are well aware of the fact that it doesn't penetrate these 3 different modalities very well. And that's the difference between SWEP source and spectral domain right off the bat. So what about image acquisition? We all know that we want to get through our clinics in a timely manner. We have hundreds potentially of patients coming in every day. They all require OCT imaging. how much of an interference is OCT angiography or swept source imaging going to be in our practice. So video A on the far left is going to be of a patient that is having a spectral domain OCT performed. The first step here is going to be to acquire a horizontal line scan with one of the competing devices. And then the patient will obtain a 3 by 3 millimeter OCT angiography image. So we can see off the bat that the machine has a unique way of acquiring image. Focusing is required before the acquisition of the image. There's processing that happens during the acquisition of the image, and we're still acquiring the single line scan for this patient. And it's a relatively nice looking spectral domain OCT image. But time is ticking, the patient gets impatient, and they may be moving. Now we want to acquire an OCT angiography image, and what we're going to see is that this also takes a significant amount of time. There are a number of OCTA devices, of course, on the market, and they all deal with motion correction in a different way. The first here in this case is to acquire a horizontal raster line scan image, which you can see, followed by a vertical raster OCTA line scan image, and then they are merged together in this particular technology to eliminate motion artifact. So you can see here the clock is ticking, the patient's still there, and the technician's working away. So every device has its own challenges. So when we take a look at the swept source Triton image, we'll do the same thing. Same patient, same day, same eye. We're going to take a single line scan using swept source. Again, patients may be moving, but we have the ability to get a good quality image. There's our single line scan for this patient. They're blinking, you can see in the corner. There's our line scan image, swept source, relatively fast. And that's one of the beauties of swept source, fast acquisition time. So now we're going to go ahead and take our OCT angiography image. This is also a 3 by 3 millimeter image of this patient, raster scan. And we can see that the difference in this case is with motion correction, we use registration with the Triton, and as a result, we can tell in real time whether the patient's moving and what kind of image we're going to be getting. So this patient's going to be getting their image, of course, and we can see as the line scans are performed, if the patient moves, we get a red bar, and it will not proceed if the patient's moving. So it's a lot faster acquisition time, there's less post-processing that occurs, and it makes things a lot more easier for a very busy clinical practice. So one thing to keep in mind that was pointed out by Voss earlier, of course, is that OCT angiography is part of the picture. And this is an example of a 6 by 6 millimeter slab. And those of us that are using ultra-wide field angiography would probably agree that angiography is not dead yet, but OCTA is one piece of the overall puzzle. So swept source OCTA is very similar to the other spectral domain OCTA devices in that we get information about the superficial capillary plexus, the deep capillary plexus, and the choriocapillaris. As mentioned, these devices all segment these layers very differently based on the way they are designed. And the segmentation lines are placed at different locations in order to achieve and obtain the information that we are looking for. So this is an example of the Triton swept source OCTA total overview that we get when we get a patient's image. This is a normal eye in a patient with 3 by 3 millimeter scanning that's been performed. We can see in the top right corner the superficial capillary plexus, the deep capillary plexus, the outer retina, and of course the choriocapillaris. And in the bottom middle quadrant here, we see a composite image. This composite image basically shows us in a color-coordinated fashion which vasculature is contributing to the perfusion that we are seeing. So similarly, this is an example of the spectral domain patient, the same patient with a normal macula, 3 by 3, and we get the similar information in both the superficial, deep, and choriocapillaris. And then our composite is given below with all the vascular layers. So not much difference when we look at a broad overview. And now all these devices also do a really good job of the optic disc. So here's an example of the 3 by 3 millimeter view of the optic disc. Again, vitreous, nerve head, the radial capillary, peripapillary capillaries, of course, and then finally the choroid. And again, we can see that it does a nice job in a 3 by 3 fashion. And then in spectral domain, we have a similar presentation of the optic disc. So when we look at these side by side, what are the major differences? At first, there are not many major differences, but we've already talked about the fact that getting through media opacities is an advantage with swept source. Obviously, the speed of acquisition can be an advantage in the case of swept source. But when we look at these particular frames in the 3x3 scan, one of the things to notice here actually is that we get a little bit more projection artifact, and that's been my initial experience with the spectral domain devices, is that there's a little more projection artifact from the layers above than in the case of swept source. One other element that those of us that are using this device may also be seeing is that the images from the spectral domain in the choroid capillaris seem a little bit dimmer. Now, whether that's in fact a function of post-processing that occurs with swept source versus spectral domain, that remains to be seen. But would it make sense? Well, we know that spectral domain 840 nanometer wavelength is absorbed by RPE and is also absorbed by lipofuscin and drusen. So a choriocapillaris view will be a lot better with the swept source because we can penetrate the RPE since there's no absorption, and we can penetrate drusen and lipofuscin better with swept source. So we would expect a brighter signal, as we do see in the choriocapillaris. So this is a high mag view that shows, again, a little brighter signal in the choriocapillaris compared to spectral domain. Whether this will be clinically relevant in the future remains to be seen as we begin to resolve the information that we see in choriocapillaris. So what about the optic disc? What are we seeing different in the optic disc? I think from the perspective of the vitreous, the nerve head, and the radial peripapillary capillaries, they're very similar technologies in terms of spectral domain and swept source. But once again, when we look at the choroid, I don't think any of us would argue that there is a little bit of a dimming of the signal in the choriocapillaris that we see in the spectral domain realm. And again, that may or may not be a function of post-processing that occurs, but it also may be a contribution from the RPE absorbing the wavelength. So this is an example of, again, of the entire slab looking at the full spectrum of all the layers of the retina in swept source and spectral domain in a normal eye. And one of the elements that I want you to notice here is that the various colored arrows here show a little bit of vascular distortion or a little bit of motion artifact that we see with both technologies. So no matter which technology we're using, we are going to get some element of distortion that we see in some of the vasculature as a result of the patient's motion that, or we would call it potentially noise, that we have to be aware of when interpreting these images. Why is that important? Because when we look at these images, they look pretty good. It's important because as we move towards the analytic software, which Vas touched upon, and looking at non-perfusion and vascular density, some of the blurring of the margins may impact what data we get back and what we may call as non-perfusion or vascular density maps in the future. So let's take a look at this other example. So one of the things we touched upon earlier was segmentation. This is a patient with myopic degeneration, and all of us will be aware we see a lacquer crack there, and there's a choroidal neovascular membrane growing. In the right side of the screen, we're going to see a short video of the spectral domain OCTA image of this patient. The segmentation lines are set at about 50 microns, okay? And we can see a nice choroidal neovascular membrane right there. And the point to make here really is that when we look at the segmentation lines here, the segmentation is set to 150 microns, and we do see the CNVM, but we don't see it as clearly. Why is that important? Because as I mentioned earlier, when comparing segmentation algorithms between machines, it's important to recognize that they may be different, and in order to get a true head-to-head comparison, the segmentations have to be matched. And in this case, we don't see a complete matching, but we are able to elucidate the pathology. So here's another example of the segmentation comparison. This is another patient with myopic degeneration, and on the left hand of the screen in the red boxes, we can see spectral domain OCT outer retinal image, the outer retina scan, where there should be no vasculature, and we see a choroidal neovascular membrane. And on the right side of the screen, we see the swept source choroidal neovascular membrane within the outer retinal slab. But once again, one thing to call your attention to is that the segmentation is different between the two devices. And that's another reason why, again, the devices themselves, it's difficult to compare them exactly head-to-head because the segmentation algorithms for these machines are always going to be different, even between other spectral domain OCTA machines. And finally, another final example of segmentation. This is a patient with proliferative diabetic retinopathy, something that I'm sure is seen very, very commonly in Latin America. And this patient has neovascularization, neovascularization elsewhere, up here above the vitreous we can see, and the same patient, same site is seen in the swept source device. And again, the segmentation is different between the two machines, and again, can be manually adjusted to an extent in each of these devices. And one of the beauties of the Triton swept source device is that the composite image really allows you to highlight some of these areas a little bit better, and we can see here this same neovascular net that we saw earlier in this lab. So in terms of angiographic analysis, we've already looked at this earlier, but all the devices pretty much allow you to scrub through layer by layer, looking at the various layers in the OCTA spectrum. This is a patient with diabetes, and as Vas pointed out earlier, the deep capillary plexus, we start to see some of these microaneurysms. Again, this is beautifully done with the swept source software. We can scrub through all the layers, and I believe in all the other spectral domain machines also, there's a similar ability to scrub through the various layers. So let's take a look at some real-world clinical cases. I think this technology, again, is in its early days. This is an example of a early wet macular degeneration patient. In the bottom right-hand corner, you can see the CNVM, and in this volume rendered image, you can see the highlighted area of the choroidal neovascular membrane. Why is this important? I mean, I think as Vas mentioned earlier, we're learning to look at this data in a three-dimensional way. We're going to get better information about the underlying pathophysiology and potentially the management based on these three-dimensional relationships that we haven't really been able to look at before. So while it looks cool, the clinical applications of looking at the overall volume, the areas of non-perfusion, the areas of growth, these are all post-processing analytical software elements that we're going to, as clinicians, probably demand from industry. So this is a patient that has Coates disease. As you can see, the ultra-wide field color, pseudo-color image on the far right hand of the screen. Far left hand of the screen, and we can see lots of exudation. The swept source OCT and the spectral domain OCTA composite images are given there. We get a little bit more detail here with the swept source OCTA image, the vascularity that we can see here with the Coates lesions. And interestingly, this patient's fovea is completely vascularized, and that's a very novel finding in this particular condition. You can see the ultra-wide field angiogram, and then finally a high mag view, really putting all this together in a multimodality fashion. Here's a patient with a hemiretinal vein occlusion, something, again, that we see very commonly in all of our practices. The swept source images are seen above. The spectral domain images are seen below for the spectral domain OCTA. Again, a little more projection artifact seen here in the choriocapillaris as compared to the swept source composite. And one more thing I call your attention to is, again, getting back to the signal and the absorption that happens from the RPE. The image of the deep capillary plexus in the spectral domain image, this image here, seems a little bit darker and less vascular than what we see up here in the deep capillary plexus of the swept source image. So again, that difference may be related to post-processing from the spectral domain side. It may also be related to absorption of the signal from the RPE. And again, as mentioned, swept source really gets through the RPE without any scattering or absorption. Here's a patient with Stargardt's disease, and we can see here the superficial deep capillary plexus and the choriocapillaris. And take it a step further, Dr. Carl Glittenberg has lent us a hand here with this particular image with removing some of the noise and the artifact, and we can see a beautiful image of the area of geographic atrophy and the large dilated choroidal vessels. And all of us know Stargardt's disease has associated lipofuscin particles that are associated with lipofuscin deposits. And in this image here, you can really see the swept source choriocapillaris, the noise-free swept source choriocapillaris, and then the spectral domain choriocapillaris. And the difference I'd call your attention to is the dark areas, which you can see here that are highlighted in the spectral domain image, and those represent the sites of lipofuscin, which we see up here. And we know lipofuscin will absorb the spectral domain wavelength and potentially manifest itself as what we call flow voids to indicate potential absence of blood flow. And the reality is that signal is being absorbed by the lipofuscin and we're getting a false representation of flow, whereas in the swept source image we don't get the same finding. So these are subtle changes. What their impact might be down the road will depend upon the analytic software that we end up integrating into these devices. Proliferative diabetic retinopathy, again, this just highlights the fact that Swept source technology and OCTA is a phenomenal technology. It is growing very rapidly, and we are able to see things almost before they're at the clinical presentation phase. This patient has some mild early neovascularization of the disc. We can see the various layers, but we can see that disc neovascularization a lot better. And again, when we look at the relationships, this is a montage rendered video. And what we can see here is that neovascularization of the disc beautifully in this video before it fully presents itself. It's really a novel way of looking at diabetes that we have not been able to look at before, and Vas showed earlier with the microaneurysms that were seen in the deep capillary plexus. How this will continue to evolve our understanding of these diseases remains to be seen, but the fact that we're looking is a step in the right direction. Sickle cell retinopathy, another common vascular disease that we commonly see. This is an example of the swept source images for this patient with the superficial deep and choriocapillaris. We can see areas of non-perfusion in the deep and the choriocapillaris. This may be some projection artifact that we're catching here. And when we look at this compared to spectral domain, we see some differences. The swept source image that we see here shows a little bit of a larger area of non-perfusion compared to its spectral domain counterpart, and the same is true here in the choriocapillaris. So again, it's hard to compare the two technologies directly head-to-head because they use different approaches to capturing and processing data, but it does give us some insight into what we might be missing and might be capturing with the various approaches. What are the future directions? When we look at this, as we mentioned earlier, this technology is very, very early days. We want to see an improvement in the segmentation algorithms. We would like to have more perfusion analysis and volume density information. All of us have been looking at ultra-wide field angiography now for a number of years, and we've whittled back down to looking at small 3mm slabs, OCTA slabs. It would be nice to be able to go into wide field OCTA. And finally, looking at a change analysis, looking at these choroidal neovascular membranes over time to see if we can make decisions based on what we are seeing non-invasively with OCTA. So basically, to wrap it up, in conclusion, I'd like to acknowledge the fact that, we are in the early days of this technology. It's an evolving imaging modality. It is using a longer wavelength with swept source 1050 that does get through significant amount of media opacities. As surgeons, we want to get through cataract, blood, hemorrhage, everything possible. Swept source offers a much more rapid image acquisition time, and that's very critical in this day and age when we have very, very high volume clinical practices. And ultimately, these technologies are both going to be limited by segmentation as well as their motion artifacts and their post-processing capabilities. I'd like to acknowledge my photographer, Dr. John Golding, and also, of course, Dr. Carl Glittenberg for his help with the images. Thank you.